Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Hey everybody, welcome back to the Wild Health Podcast. Mike Mallon. I have Dr. Reta Graham with me here today, which I'm super excited to talk to about perimenopause. Dr. Graham is a board-certified obstetrician gynecologist who's worked in the U.S. and abroad for 20 years in private practice, global health, and the academic setting. She's collaborated with resource-limited communities to address such challenges as maternal and infant mortality and gender-based violence. In 2014, she and her husband co-founded Mama Misha, an NGO that partners with local women as advocates for maternal and reproductive health. She lives in Western North Carolina with her husband, Dr. Jeffrey Graham, and their 2 children, and works as an OB hospitalist. And she has a particular interest in functional medicine as it applies to the perimenopause and menopause, which is exactly what we want to talk to Dr. Graham about today. Rita, say hi.
Hi. It's great to be here.
Thanks for being with us today. It's great to have you here. I really want to talk about this topic because it is an area that has, been illuminated to me as a giant challenge in the practice of medicine for any woman anywhere near perimenopause, and even outside of perimenopause for that matter. Just later period of life, and then postmenopause as well, are just these giant challenges. And I feel like areas that the medical community has basically ignored for the last, I don't know, ever. And we just don't really understand how to treat them and how to support women through these really challenging periods in their life. And I know you have your own personal story, which is obviously very challenging, has brought a lot up for you in terms of managing this for yourself and then for other women. So maybe a good way to kind of start this conversation would be, if you're willing, to share with us a little bit about your journey over the last couple of years with regard to your own sexual hormones and your experience through this aspect of life.
Yeah, absolutely. So I am a breast cancer survivor. I'm 5 years out from my initial breast cancer diagnosis. So I was actually diagnosed at 41, which is pretty young. At that time, I was training for a trail race here in Western North Carolina called the Shut-In Trail Race. It's 18 miles uphill. And completed it the day after I had my breast biopsy. So I was in the midst of really feeling physically very good. Thankfully, my cancer was picked up really early, and I had a surgical cure. So I went through an initial mastectomy and didn't have to have further treatment, which was great. I did take some time off from work then to just rest and heal and sort of reevaluate my life. And that was when I transitioned to being an OB hospitalist. In the spring of 2022, I underwent a hysterectomy and removal of tubes and ovaries, BSO. My cancer was an estrogen responsive, progesterone responsive breast cancer. And at that point, I was dealing with heavy menstrual cycles and fibroids, and was not able to access the typical treatments that would be sort of first line, which oftentimes would be hormone treatments. And so I opted for surgery. And I was at the point where I was comfortable moving into surgical menopause, knowing that when my ovaries were removed that I would be in menopause. And as such, having the hormone responsive breast cancer, I was not a candidate for hormone therapy post-operative. So I met Wild Health actually in the midst of all of that, and really at this point now, a year past that surgery, I'm feeling about as healthy as I've ever been in my life. So that's my journey.
Oh, congratulations on having a positive outcome to that journey. I'm so sorry that you had to go through all that, but it sounds like things are on the up and up as much as they can be.
Indeed.
Yeah. What was your experience like, going through? I mean, sort of thrust into menopause like that, rather abruptly. It sounds like. Tell us a little bit about that experience and some realizations that you've had around that in terms of other women's experiences with menopause.
Well, I had the privilege of caring for patients for many years who also had gone through menopause, either naturally or surgically. So I did, unlike some people, some of my friends, I did have a little bit of understanding of what it might be like. I did know that it was going to be a big challenge. I underestimated the degree to which the emotional changes and just the changes in my body would disrupt my overall sense of well-being. So I did a lot of work before having surgery and then continued, that work afterwards. I have friends who joked that my sort of entire existence was doing something to make my physical, mental, emotional, or spiritual health improve during that time. So it was really hard. It was really hard. It was as hard as you hear anybody talking about. I experienced the mood disruption, sleep disturbance, hot flushes, brain fog, change in libido, all of those things. And I had the privilege of being able to access the health system pretty easily and get the care that I needed. But I did incorporate Western medicine and also Chinese medicine, and used physical exercise and mindfulness and meditation as ways to address that.
It seems that this is something that affects almost every woman I've ever met to some extent. There's like the unicorn out there who's like, well, yeah, but I mean, but realistically, there's like a unicorn here or there who's like, my periods never bothered me, and then I went through menopause and barely even noticed, and I feel just fine. But that's definitely not the common denominator, right? Like that's not what we typically see. Why do you think it is that we have such limited treatment modalities for this process? Is it just sort of is it all just like inherent sexism in the medical culture since the beginning of time? Is it that simple, do you think?
I think that that's a huge part of it. You can look at differences between the United States and the United Kingdom, for instance. And I like to sort of dig into the way that other countries are handling public health initiatives. And in the United Kingdom, within the last several years, there was an organization that petitioned Parliament to make menopause a public health initiative. Imagine that. In the United States, the story really has changed over the last 20 years, especially. So I was a resident in 2003, and the Women's Health Initiative study had just come out. And the narrative prior to that was really, these hormones, which for the most part, in the pharmaceutical companies who made Premarin and Prempro, they were using, estrogen from mare's urine. And for those who are listening, if you have a uterus, you do have to take estrogen along with progesterone if you're having hormone therapy. The estrogen handles a lot of the symptoms. The progesterone protects the lining of the uterus from thickening abnormally, which could progress to a uterine cancer. So during that time, prior to that study, everyone really saw that hormone therapy was going to be something that every woman should take, and she should take it for the rest of her life. Which was beneficial, to a lot of women. But that study, unfortunately, looked at a group of women who were more than 10 years out from their menopause, and many of them had significant risk factors for cardiovascular disease and venous thromboembolism. And they stopped the study because they saw an increased risk of breast cancer in the arm that was receiving estrogen plus progesterone. And that risk was actually, the impact of it was not so large. That I don't have the numbers right in front of me. I think it was like 8 increased cases per 10,000 women or something. But because of that, they stopped the study. And so the media, the response to that was so mishandled at the time that, women were really scared, providers were really scared, and everybody just got off their hormone therapy. So, thousands upon thousands of women who had been taking hormone therapy for some time suddenly without it because they're scared to death that they're going to get breast cancer. And the last 20 years, the narrative has really sort of swung back to this middle ground where we can see some places where, no, this therapy is very important. It does actually benefit women, but they need to be appropriate candidates. And actually, I forgot what your original question was.
I did too, but whatever you just said was perfect. I think it might be good if maybe we take a step back for a moment and make sure that the listeners caught up with what these hormones are, how they function in the body, what their roles are. And maybe we can start with just sort of the sexual hormones, what they are, what role they play in regular menses for women. And then after that, maybe we'll dive into like the mental health effects a little bit, if that sounds good.
That sounds great. So just briefly, hormones in general are specialized molecules that are secreted into the bloodstream from endocrine glands, and they target specific cells or specific organs, and they exert specific effects. So in effect, they're chemical messengers. And, the sex hormones in women are predominantly estrogen and progesterone. In men, they're testosterone. Both men and women produce DHEA, which comes from the adrenal glands. Estrogen and progesterone, are predominantly produced by the ovary, and testosterone by the testes. So in medical school, I remember thinking that anatomy-wise, women and men are, approximately the same in regards to complexity, but hormone-wise, women are so much more complicated because we have the menstrual cycle. So, that is something that I wish that we taught in a little bit more detail in our schools, because I think it could really help girls and women to understand, themselves and their cycles better. So women have higher levels of estrogen and follicle stimulating hormone. The estrogen hormones that women have include estradiol, estrone, and estriol. And these are the ones that are responsible for female sexual characteristics, including the initiation of puberty, menses, and supporting pregnancy. So progesterone is the second female hormone that is primarily involved in the menstrual cycle, but as well as in supporting pregnancy and maintaining the uterine lining. And then there are other hormones that include luteinizing hormone, follicle stimulating hormone produced by the ovary, which helps with ovulation and menstruation, and the production of estrogen and progesterone. And then we have prolactin, which is active during lactation, and human chorionic gonadotropin, which is produced during pregnancy and helps to maintain the early development of the placenta. And oxytocin, which is not a sex hormone, but it is very active during childbirth with uterine contractions and during lactation, allowing the breast milk to let down. And it also plays a key role in emotional bonding and social behavior, which makes a lot of sense with women and their babies and parenting. And then in regards to mood and well-being, in general, estrogen and progesterone do promote a sense of well-being and relaxation in women. They also interact with neurotransmitters in the brain and those neurotransmitters are certainly affected by the levels of estrogen and progesterone, and the stress response as well. So depending on what stage of life you're talking about, hormone therapy can have a profound effect on a woman's mental health, and can be a very valuable tool.
So important to note, I guess, that these sex hormones, both sexes have them, right? So, men have estrogen, women have testosterone. This is well established, but there's different levels, right? And then you mentioned this earlier about around the complexity of women's hormones. Men, we make a lot of testosterone in the morning, we make less in the evening, and it's just kind of goes on a daily cyclical nature. Whereas women are changing on, a 28, 32, whatever day cycle, where there's this variation in the production of estrogen and progesterone.
Yeah.
And it's my understanding that we think that this variation has a lot to do with sort of some of the effects that we see, obviously the natural physiological effects where your menses and all of those things, but also the mental health effects or the effects on mood that we
Absolutely.
see with these medications. Talk to us a little bit about what is happening during that cycle, and if we know, and my guess is we don't really know everything, but if we know how those changes might be affecting mood.
Sure. So when you think about the female menstrual cycle, we date day 1 as the first day of menstruation or bleeding. So the menstrual phase is typically days 1 through 5. And during that time, estrogen and progesterone are at their lowest levels. So that has a very significant impact on mood. Many women will experience mood swings, irritability, and fatigue, as well as physical discomfort associated with menstruation. So this is really a time for women to be extra gentle with themselves, to pay attention to how they're feeling.
Mm-hmm.
But conversely, it's also a really good time to do vigorous aerobic exercise, because
Not
you
intuitive.
get a release of yeah, and that actually is benefiting you during the time when you're feeling uncomfortable. Endorphins are our body's natural painkillers.
Mm-hmm.
So, when I was menstruating, I always made sure I was running during that time, just to get outside, to move my body,
Mm-hmm.
to feel the effects of, the endorphins that are released after a certain amount of time of, having a heart rate up and moving and breathing. During the follicular phase, that is that first sort of 2 weeks or so of the cycle, the estrogen levels do start to rise. And this is so that the eggs in the ovaries, there'll be a dominant follicle that will come forward, and it'll be the one that's picked to ovulate, basically. And so as estrogen levels rise, women do note an improvement in mood, and they may also note some increased energy. And then during ovulation, estrogen peaks right before the egg is released from the ovary, which is what we call ovulation. And a hormone called luteinizing hormone surges to release the egg. And during this time, a lot of women will feel a boost in mood and energy, and they might feel, just a little bit more confident or social. But there are some women who experience a little bit of increased irritability during that time as well. And then the luteal phase of the cycle is the second half. And during this time, the estrogen and progesterone levels continue to go up. If the woman becomes pregnant, then those levels stay high to support the pregnancy initiation. And if she doesn't, then that's when estrogen and progesterone both fall dramatically. So and then the cycle starts over again. The lining of the uterus sheds, the luteum goes away, and we're back at the beginning of the cycle.
And what of that?
It's a roller coaster.
Yeah, it is. Certainly. And what of that cycle contributes to the symptoms that we hear so often about premenstrual syndrome or PMS or PMDD? Where do those mood changes come from? Do we know?
Yeah. So it's important to highlight too that like the variations of those hormonal fluctuations are going to be very different person to person. So for some women, they really don't notice a big change in irritability or how they feel. But for others, as you mentioned, they may have changes that actually are significantly impacting their life. And so mostly you can just attribute it to low levels. Those are anabolic hormones that during that time, all of the aspects of our metabolism are sort of in peak performance mode.
Right.
And when those levels are low, there's changes in neurotransmitters in the brain. There's all sorts of things happening where we just don't feel like ourselves.
And there's different variability in different periods of life as well, right? Just in terms of the cycle. So, the cycle that you have in your 20s is different than the cycle in your 30s, which is different than your cycle in your early 40s. Do we understand that in any way, or is that just so variable across the population that it's hard to really make any generalizations about?
Well, from the perspective of someone who's a practicing gynecologist, what I hear from my patients and what seems to be, playing out, I think, in the studies that we see is obviously as we're aging, the number of functional eggs that we have in our ovaries are less. And so those drops, those estrogen and progesterone drops tend to be a little like more precipitous. So the premenstrual symptoms and the experience of women, and sort of in that time in their cycle can be more significant as we age. There are certainly things that we can do to address that. And I, this is something I figured out for myself, I think, rather than really being taught this in medical school or residency. But what we eat has a huge effect on how we feel. Physical exercise, adequate sleep. In the perimenopause and menopause, with dropping estrogen levels, we're actually less efficient at taking the glucose that we're getting from our food sources and from our bloodstream and using it. Instead, we tend to store it as fat in our belly. So that can be really frustrating for women who are very physically active, and then all of a sudden their body's changing and they don't understand why. So there are things to do to mitigate that as well.
Maybe we sidebar on that for a minute. That sounds like something that could be really useful for our listeners. So what you're saying is that there's obviously these hormonal changes, that are naturally occur in a cyclical nature on a monthly basis. That the cyclical nature of those hormonal changes also has a lifetime curve where over your lifetime, as you get closer to menopause, a lot of women seem to notice these changes in the hormones more, possibly because of the amount of follicles that are valid in their ovaries. And for that reason, there are things that we can do from a lifestyle perspective, it sounds like, that would potentially improve these symptoms in what I guess we presume we describe as perimenopausal. Is that true? Are we really truly in the perimenopausal stage at that point, or is it even like menopausal?
So that's a great question. So the definition of the perimenopause is the 5 to 10 years prior to the menopause.
No, that's very broad.
And the menopause is cessation of So it's a very significant span.
Yep.
And so the menopause is cessation of menses for 12 months in combination with symptoms of menopause, like vasomotor symptoms.
Right.
So perimenopause, is that 5 to 10 year period, and that's a significant portion of a woman's life. Oftentimes it's when she's in a very highly productive setting in her professional life. She has children maybe in school, partners, and maybe is taking care of aging parents. There's a lot going on during that stage of our life. So it's really important to make sure that we're actually living our best life during that time. And that's like the worst possible time to suddenly feel like your body's being turned inside out and you don't recognize yourself at all. So some things that I think about that I've learned for myself, one of the biggest lessons I learned was that I'm pescatarian. I do eat fish, and I mean, I'm pretty, I'll eat other things as well. But when my health coach sat me down and we started counting my protein intake, I was not getting what I needed from that perspective. And, in fact, I know you know this way better than me, but the amount of protein that we should be getting in order to maintain and build muscle is like 1.2 grams per pound of body weight, which, is it for people who aren't familiar with that, seems like an insane amount of protein. But once I started addressing that, and I'm coming from a place of no hormone therapy, I'm, menopausal, not getting estrogen replacement, my brain fog and emotional lability disappeared. It was incredible. Just getting adequate protein. And that makes sense because, then we've got the building blocks of what we need to make neurotransmitters, to do this gene transcription, to do all the things that we need to do to maintain muscle mass and to function well. So that was a huge thing for me. And then maintaining adequate hydration in menopause, it's more difficult to stay hydrated just with changes in our metabolism and changes in our hormones. And so I really focused on that, on hydration and electrolyte replacement. And then physical movement really needs to change at that time as well. I have a lot of girlfriends who we all run. We trail run here in Western North Carolina. It's a beautiful place to do that. Yeah. But it's not the best primary means of exercise for a perimenopausal, menopausal woman. In fact, if you have somebody who is exercising aerobically and they're doing what they've always done, what they did in their 20s and their 30s, and now they're perimenopausal and menopausal, they suddenly notice, well, their times are slowing and I feel really fatigued and I'm having these crazy food cravings and all these things are happening. And so they cut calories because they notice belly fat and they want to address that. And instead of doing that, which actually contributes to worsening the problem, they need to add healthy complex carbohydrates and protein and time that in relation to their workouts. And so that's very counterintuitive unless you're actually, more informed or you have somebody telling you this.
Yeah. And would you change that? Would you change their diet or have them change their diet based on the timing of their cycle as well? So certain periods of their cycle where you would have more protein, more carbohydrates, things like that?
So around the time of the, like that premenstrual period, oftentimes women do have cravings for sugar, carbohydrates. It is beneficial to have complex carbohydrates during that time. It's not really beneficial to do the highly processed, high sugar kinds of foods, just because it puts them at a higher risk for that glucose crash that, results in emotional lability. For perimenopause and menopause, insulin resistance actually increases. And if you're not addressing that, cortisol levels are increasing as well, just in response to kind of our standard stressful life that we have, in the United States. And so if you do nothing different, you do continue to feel sort of worse and worse. So it really is a time for providers to be aware of these things, because it's a great opportunity to counsel women about ways that they can actually improve their health span, improve their longevity, and make a big difference for decades. Just from the perspective of muscle building and bone mass.
Okay, so I heard fitness, nutrition, and hydration are the primary lifestyle interventions that you mentioned so far. Anything else that you would throw in there?
Well, and sleep. For me not to say that would be terrible. Sleep is probably after exercise is probably the most important thing. And unfortunately, estrogen is a hormone that actually helps. Like, it decreases our latency to sleep. We sleep deeper. We stay asleep longer. And so lack of estrogen does the opposite of all of those things. So sleep disturbance is a huge problem for women as they're going through perimenopause and menopause. And there are, there's lots of information out there about sleep hygiene and things that can make a difference for that.
So average age for menopause, 47, 45? I can't remember off the top of my head.
No, it's 51 in the United States.
51. Okay. So not unreasonable to be experiencing this in your early 40s for sure.
Right. Absolutely.
Yeah.
And it's important, that during that time to make sure that you establish care with someone who is comfortable caring for a woman as she goes through that perimenopause time period. Because there's a lot of symptoms that can be addressed with lifestyle modifications.
Let's say you've got somebody who is really tuned in, and they've been suffering from some of these symptoms for a couple of years, and they've made all the lifestyle interventions that you've suggested here. When do you start thinking about HRT, hormone replacement therapy? When is that? And what does that look like? Does that look like birth control pills? Does that look like estrogen patch? Walk us through that thought process for you.
Sure. So it's going to depend on the age of the woman for sure. So if she is still in her reproductive years, i.e. she's still having cycles, and she's experiencing symptoms of perimenopause, a low-dose oral contraceptive pill is a great option because she's actually getting estrogen and progesterone, low levels of that to help with some of those symptoms that we were talking about. And she's protected from an unwanted pregnancy. It would be really doing someone a disservice to tell them, oh, you're perimenopausal, you don't need to worry about pregnancy anymore. I've seen spontaneous conceptions happen at 50. So if somebody is in that place where they're still having cycles, they absolutely could have a pregnancy, and they need to be protecting themselves against that if they don't want to be pregnant. Right. Once a woman has actually reached menopause, so she's been, 12 months with no cycles, and she also has symptoms of menopause, we call it hormone therapy. It used to be called hormone replacement therapy. Now we say hormone therapy. And it's typically estrogen with progesterone if the woman still has a uterus. So the safest way to get estrogen is actually in a transdermal formulation. And so you can do that with patches, sprays, topical creams or lotions. And then a really effective way to protect the uterus from the endometrium getting too thick or developing a precancer or cancer with unopposed estrogen would be a progesterone releasing IUD. So that'd be a kind of my first line for somebody who is menopausal or, is in that perimenopause with significant symptoms.
Gotcha. And so you said typically it's a estrogen patch and then a progesterone pill, it sounds like.
Progesterone releasing IUD, intrauterine device.
Oh, progesterone releasing IUD. Oh, okay. Gotcha. Okay.
And you can do a progesterone pill, and that's fine as well. But the IUD has the added benefit if she's in that time period where she's still, potentially could have a spontaneous ovulation, then she's going to be protected from pregnancy.
Yeah. And this is a good time to remind everyone, you've already mentioned it once on the podcast, but I think the more we mention it, the better, that we don't want to do estrogen only treatment in women who still have a uterus, right?
Exactly. That is something that would be very dangerous and put them at risk for endometrial cancer.
Right. Which is generally considered bad. Okay. So we've talked a bit about perimenopause and sort of those symptoms that we can see and cyclically leading up to perimenopause. Let's talk a little bit more about menopause itself and sort of the expected course of menopause for women. Talk to us a little bit about that. Like when you said 51, what is it? What does that time period look like for a woman, and what sort of symptoms should they expect over that time period?
Well, the most common symptom that's bothersome to women is hot flushes, what we call vasomotor symptoms. And 80% of women are going to experience those. Hot flushes lead to a lot of other issues, including decreased sleep quality, irritability, not being able to concentrate, decreased quality of life. It's like you are just sitting there minding your own business, and then all of a sudden, your body is on fire. Some women have nausea. Some women have palpitations and increased anxiety. I've heard many women talk about thinking they were dying. It could precipitate the feeling of a panic attack. If you don't know what it is, it's really scary. So very disruptive to a woman's life to be in the midst of her board meeting, for example, and all of a sudden she's pouring sweat, feels nauseated, and thinks maybe she's having a heart attack in the midst of that meeting. So the number one treatment that's FDA approved for vasomotor symptoms is hormone therapy.
Yep.
Other women talk about things like joint pain. You can have some digestive disruption, genitourinary symptoms, urinary frequency, pain with sex, decreased lubrication, decreased orgasm, all of those things. For women who experience genitourinary problems, topical estrogen is actually the first treatment that we would recommend, and works more effectively than even systemic hormone therapy. So women who have had breast cancer are still candidates for topical estrogen therapy for those genitourinary symptoms.
And how long do we expect these symptoms to persist after or during that menopause phase? I mean, they start prior to menopause, right? Like, so you see like a crescendo of vasomotor and genitourinary symptoms coming up to menopause, and then afterwards, do we see the vasomotor symptoms decrease? Is that expected?
So some women will experience them for 6 to 10 years.
Yeah.
I personally started venlafaxine. Low dose 37.5 milligrams is indicated for hot flushes. And it's a great option for women who can't take hormone therapy. There are other options that have been shown to be helpful. The North American Menopause Society is a great resource for any listeners who want to dive a little bit deeper. They have great patient information there, and providers who are certified by the North American Menopause Society are going to be really well-versed in taking care of menopausal patients. But I was taking a peek at some of their position statement on non-hormone therapy, and it was interesting. So one of the things that I do, which I think works, but NAM said they need more studies, are cooling techniques. So I have a mattress that cools, and it absolutely helps me. And I know this because if I'm on vacation someplace else, I'm having hot flashes at night, night sweats. But if I'm at home, I have none. Another thing that makes a difference, and this is sort of falls under that lifestyle modification category, alcohol actually significantly increases the experience of hot flushes, and we know that it causes significant sleep disruption as well. So for menopausal women, sometimes they'll just say like, I just need that glass of wine before bed to sort of calm me down, but it's actually one of the worst things we can do because it's going to disrupt our sleep. For those of us who experience hot flushes, it makes it worse, and so it's not something people want to hear, but that's definitely something that's true.
So no booze, and get a cooling mattress or a cooling mattress pad. It sounds like some reasonable.
Made a difference for me.
Yeah. Good. Anything else that natural treatments that we can use for some of these symptoms?
So hypnosis has actually been shown to make a difference in the frequency of vasomotor symptoms, as well as the patient's perceived difficulty from experiencing vasomotor symptoms. So I thought that was really interesting. And cognitive behavioral therapy as well.
Okay. Good stuff.
There are other FDA-approved medications for the treatment of vasomotor symptoms, and those include the medicine paroxetine, and I already mentioned, I think, venlafaxine, which is a serotonin norepinephrine reuptake inhibitor, as well as gabapentin and actually oxybutynin as well.
This is a lot. I mean, there's a lot of changes happening during this period in women's lives, and a lot of different modalities to treat it, right? And it seems like there's not a consensus as to what the right modality is. At least, I know there's consensuses within different groups of thought, but there's a lot of opposing groups of thought here around, when to use hormone therapy, what kind of hormone therapy. Should it be lifestyle oriented first? Should we be using SSRIs? Like, just so many different groups of thought. I mean, what is a woman to do to figure out how to navigate these waters? It's a lot to figure out.
Well, Mike, I have been gifted a little bit of time. I had a knee surgery, and so I'm spending more time at home, not currently on shift. And I'm writing about this because I feel like the last year of my life was really focused on getting back to a place where I could say I was living my best life. And it was a huge amount of work. And I do feel like I have this body of knowledge that has worked really well for me. And then I have the unique, ability to sort of look at it from the perspective of an OB-GYN. And there's so much information that I've learned that, I didn't know. And it's been because I've been doing my own research for myself. And now, it'd be great to be able to share that with others. But you're right. There's a lot of information out there. And we're learning more and more every day.
And not, what works for one woman might not work for the next woman. Like there's variability
Right.
in terms of how people are going to respond. What's been your top, let's say 5, see if you can give me 5 things, top 5 for improving or allowing you to live your best life during this transition?
Well, for me, not using hormone therapy, I would say not drinking alcohol, getting adequate protein in my diet, and adding predominantly strength training and plyometrics as opposed to, just doing my Peloton and my trail running. And then breath work and cold therapy. So those are things that I had not done previously. And to get into an ice bath when you're in the midst of a hot flash is like the most amazing thing ever. And I do notice that it seems like my vasomotor symptoms are better when I'm doing sauna and cold plunge. And I haven't had a chance to dig into whether or not the research supports that.
Okay, yeah, I was about to ask.
You want me
so in your case, it's worth noting that you can't take hormones because of your breast cancer history. So that
Right.
cannot be in your top 5. But the top 5 you mentioned were no booze. It was the cooling pad, right? Strength training and plyos. We hadn't talked about that. You talked a little bit about how women need to be careful with aerobic training, but maybe talk with us a little bit about strength training. Why do you think there's benefit with strength training specifically in this group?
Well, this is something that I'm learning from reading and watching Dr. Stacy Sims, who's a PhD physiologist who studies gender differences with nutrition and physiology. And in women, specifically perimenopausal and postmenopausal women, estrogen previously functioned to make their muscles, the actin and myosin bond really strong. The ability to build muscle in response to, strength training was very efficient. When estrogen's not there, we lose this impetus to build muscle mass, just as women. So to counter that, we have to increase the protein that we're taking in, and then we have to change our training so that we're really making our muscles make those epigenetic changes to build mass. So she's the one who, of course, my husband would say he's been telling me this all along, but I had to read about it.
Of course.
I believe him. So the plyometrics, the like jumping lunges and burpees and, box jumps. I have a friend who's a dancer, and she said, in ballet class, they do slow movements and then they do the quick movements, and the quick movements would be an example of plyometrics. But those are going to feed forward to build muscle mass. And then in addition to that, the high intensity interval training helps us build bone density. So both of those things are really important in the perimenopause and menopause, because if we do nothing, we're going to lose about 3% of our muscle mass every year, and our bone density is going to decrease significantly.
Probably all the more important in someone who is unable to take hormones.
Yes,
post-menopause as well, right? So putting weight on your back, putting that load on your spine is, extremely important in that aspect. You also mentioned breath work and cold therapy. Let's talk for a minute about those. What sort of breath work are you doing, and how have you found that to help?
I am mostly doing, I guess, what I would call like box breathing, that in response to, being hyperadrenalized in the midst of our stressful world. So I like to do breath work that activates my vagus nerve. I like to get into that sort of tend and befriend parasympathetic space. So box breathing, what I do is just breathing in for 4, holding for 2, breathing out for 6, holding for 2, or you can do it, the same on breathe in for 4, hold for 4, breathe out for 6, hold for 4. You want the exhale to be longer than the inhale. And when I do this for 20 or 30 minutes, I have a Whoop, and so it shows me my recovery the next day. My heart rate variability is always so much better, and the quality of my sleep tends to be better as well. So I'll do that as I'm falling asleep or any other time during the day when I feel particularly adrenalized. And then the cold therapy, we have a sauna at home, and we have a cold plunge. And so going from the sauna where I've got my heart rate up and I get into that cold water, up to my neck, I start doing that box breathing, and I can feel the heart rate slowing. I can feel the effects, just within seconds, really. And it seems like the mood effects seem to last for hours after that as well. So I used to try and go to the beach in the winter to make sure that I could deal with the seasonal affective feelings. And last winter, just doing consistent sauna and cold plunge, it was incredible. It made such a difference.
Oh, really?
And I
Interesting.
would love to go to the beach, but I didn't.
I'm not sure if that's cheaper or more expensive, having a sauna and a cold plunge.
Well, our cold plunge is a horse trough. You can get that for $30 at Lowe's.
Okay, yeah, that's not a Hawaii beach vacation. That's a little bit different.
No.
Awesome. Well, Rita, this has been great. What else do you want to share with the listeners about this topic?
Well, I really want women and girls to feel comfortable talking about the differences between women and men. This is something that I really feel like we do a disservice to girls, especially as they're going through changes with puberty, and maybe they're, athletes and their bodies are changing and they don't understand what's happening. And we just treat them the same as the boys, when really, they're so different. And a lot of girls give up on athletics during that time because it just feels really uncomfortable to get your period or to have something happen, where you feel embarrassed. And if we normalize it, then those girls hopefully would stay in some sort of athletics and maintain, a relationship with movement in their life that's going to really benefit them. So I wish that we talked more about it. I think that would make a big difference.
Well, we're starting right here. And
yes.
We can certainly, hopefully, encourage those people listening to this podcast to talk with their children about it, and just to be a little bit more open in the discussion about women's hormones and cyclical life changes in general. I think I thought about putting sort of a sort of PSA at the beginning of the podcast that this might be a topic that only the women click on in the podcast feed, but hopefully the men out there recognize as well that this is an important topic for them to listen to and understand, so that they can support the women in their lives. And I venture to assume that just about every man has a woman in his life that he can support through this period. So
absolutely. And using reputable sources to get information. Not TikTok, going to the American College of OB-GYN or the North American Menopause Society to get information, making sure that you're an advocate for yourself when you have conversations with your doctor. And if they blow you off, if they're not listening and you don't feel heard, then you keep looking until you find someone who does hear you, because there are really great practitioners out there who are staying up to date with the studies and are providing really great care. And I'd like to give a shout out to my health coach, Michelle Miller at Wild Health, because, she has really improved the quality of my life with her excellent coaching information that she's given me.
That's awesome. Yeah, I like the not TikTok comment. That's definitely not the place that you want to get your healthcare advice. And also the comment about searching for the right doctor. We've mentioned now multiple times that this is not stuff that we learned in medical school. So, because one doctor or one physician or clinician that you're meeting with doesn't have good answers for you or doesn't seem to be listening to you, that does not mean that that's the entire medical community. So shop around and find somebody who knows what they're talking about.
Absolutely.
Well, Reta, thank you so much for coming on the podcast. This has been great. Loved having you here, and we'll have to have you back for more later. Yeah.
Thank you, Mike. It was fun.
Awesome.
Hey everybody, a quick note about our precision medicine training program. It's been a really popular course. We're constantly hiring health coaches and physicians, but we're only hiring them as we grow if they're trained in precision medicine. You don't get that in medical school or other places. And so we've developed this training program, and we've completely revamped it recently. It's a lot more robust. So now there's still over 50 hours of live synchronous training. There's also all the asynchronous credit, over 50 hours of content. And as a physician, you get about 50 hours of AMA Category 1 CME credit, which is a nice benefit. For the health coaches going through the training program, it's now accredited by the National Board of Health and Wellness Coaching. So graduates are going to meet the requirement to sit for the board exam and become board certified health coaches. So there's a lot of benefits to that, not just the certification, but also when it comes to things like insurance reimbursement. So it's a really robust program. If you're a physician, a nurse practitioner, a PA, or someone that just wants to be a health coach, it's open to all of those categories. There's the 6-month program that's kind of the full program. And then we also have just a fundamentals of precision medicine course, which is completely on your own. It's online. It's all asynchronous. You still get the 50 hours of AMA Category 1, but it's self-paced, and you still have access to the online community, but not all the synchronous lectures as well. So if you're interested in checking that out, go to wildhealth.com/education, and we'd love to have you as part of our next class.